Good evening. Thank you all for joining us for tonight's webinar, where we will be discussing the early clinical results of the BEAR clinical trial and the interim analysis of the Bridge Registry. It's my pleasure to introduce you to our speakers. We have Dr. Keith Baumgarten from the Orthopedic Institute in Sioux Falls, South Dakota. He's also our lead PI on the BEAR clinical trial. We have Dr. Jacqueline Brady from OHSU in Portland, Oregon, who's a lead PI on the Bridge Registry, along with Dr. Sabrina Strickland at HSS in New York. And lastly, we have Dr. Jocelyn Wittstein, who's our lead clinical writer for the Bridge Registry and is out of Duke. Thank you all for joining, and Dr. Strickland, I'll let you take it from here.
Good evening. My name is Sabrina Strickland, and on behalf of Miach Orthopedics, tonight we're going to talk about the early clinical results and essentially the post-commercialization use of the BEAR implant. Tonight we have Keith Baumgarten from Sioux Falls from the Orthopedic Institute there, Jackie Brady from OHSU in Portland, Oregon. I'm from HSS in New York, and we have Jocelyn Wittstein from Duke in Raleigh, North Carolina. So as far as a commercial update, there have been over 4,000 patients treated commercially with the BEAR implant since its launch in 2021. That's a question I get a lot from patients as far as how many have been done, how many have I done. As far as the types of tear that have been treated, 66% of them been proximal, 16% mid-substance, only 2% distal, and 16% of them were partial tears. Age breakdown, at least how I started, when I started using BEAR, it was all in the over 40 or over 35 group, but it's just 25% of patients, 30% were 26 to 39, 14% between 19 and 25, and 31% under the age of 18. There's 495 users, and that's spread out over 418 institutions in 48 states. So to just very briefly review the clinical trials, and we'll get much more in depth on BEAR and the Bridge Registry, but BEAR was just the feasibility study, and all those patients were followed through 6-year visits. BEAR is the pivotal trial to get through the FDA. It was they now have 6-year data, and their 6-year visits are ongoing. The label, and we'll talk about that in a second. BEAR is what Keith will talk about. That was a label expansion study. The age was expanded from 14 to 62. All those patients were under 50 days from the time of injury, and 151 subjects. BEAR is currently enrolling. It's got 128 out of 150 subjects enrolled, and this is BEAR versus BTB. All these patients are over the age of 18, and all the injuries are less than 50 days. And the Bridge Registry that some of us are on this call are involved with is a post-market real-world evidence study. So essentially, we can do BEAR however we want, and we're not limited by strict surgical techniques. The age range is 7 to 70 years of age. The time from injury to surgery is 8 to 154 days, and so far there's 224 subjects out of 750 enrolled. So briefly, the initial pivotal study was 100 patients. This was published by Martha Murray in 2020. The median age was 17, 65 bears, 35 hamstrings, 96% 2-year follow-up. And essentially, there was very positive results as far as IKDC, side-to-side difference. Revision ACL rates was statistically the same. And just of note, historic primary pair in adolescents had failure rates approaching 50%. They had no failures in patients older than 20. And the revisions, notably, were noted to have similar primary outcomes compared to a primary ACL, which is very different from the revision ACL literature. So in this study, all of these patients had an MRI after surgery, and what was noted at 24 months was the ACL cross-sectional area was similar or equivalent to the uninjured knee, and the ACL signal intensity, where on this graph lower is better, was similar to an ACL reconstruction as far as quality and organization. in this study, essentially the bears met all primary and secondary endpoints. So looking at IKDC, ACL reconstruction versus bear, 85 versus 89, instrumented AP laxity, 1.6 ACL reconstruction and 1.6 for the bear. And this I thought was most impressive when I first read the study was that even at 2 years, ACL reconstructions after hamstring autograft only regained 63% of their hamstring strength versus bear. Of course, since there was no donor, site morbidity was 98%. On the next slide, there was a trend, but just a trend towards less contralateral ACL tears. And only one of the contralateral ACLs was after a revision ACL after they'd failed their bear. And re-tear rate was in line or lower than current standard of care. So here you can see ACL reconstruction, the control was 5.7%, Moon was 11.7, Bear was 13.8, so statistically in line. I think this also is somewhat compelling and helpful to tell patients because what was noted was that the revisions were easier. There's just a button in this trial on the femur. So essentially when you're revising a bear, it's essentially like, or akin to doing a primary ACL, and instrumented AP laxity after the revision was similar to a primary ACL. IKDC, you can see the bear patients at 6 months. 40% of them had an IKDC greater than 90, while only 11% of the ACL reconstruction patients. So certainly getting back to activity and function much more quickly than a standard ACL reconstruction. And lastly, the Mark scale. So in the BEAR 2 trial, 86% of the bear patients and 70% of the ACL reconstruction returned to some level of pivoting sports at a year. So certainly a very high return to sport level in this trial. So next, Keith is going to talk about the BEAR 3, which was not a randomized trial. He'll tell you all about it.
Great. Thank you. So I'm tasked with discussing the early clinical results of the BEAR 3 study. We're going to present 1-year results here during this webinar. Can we have the next slide, please? So there are 11 participating sites in BEAR 3. To increase generalizability of the results and conclusions, there's a mixture of private practice and academics including in this. We do have a representation of blue and red states. And we do have both East Coast and West Coast representation, just in case 90s rat preference makes a difference in outcomes. So we got it all covered. Next slide, please. So to be a part of this study group, we had to use the original BEAR technique described by Dr. Murray, which does deviate from the registry itself. And this was the same technique used in the BEAR 1 study and the BEAR 2 studies that are referenced here on this slide. Next slide, please. So the first aspect of the BEAR technique is arthroscopically accessing the ACL stump to make certain that the patient's an appropriate intraoperative candidate for the BEAR procedure. Next slide. So once determined that a patient is indicated for BEAR on the back table, we have our surgical tech load a suture button that will be placed on the femur with 2 number 2 Ethibond sutures, and the surgeon performs a notchplasty. Next slide. So next step is drilling a femoral tunnel, which is wide enough to pass the femoral button. And we do pass a shuttle suture, and we do an open cut down over the lateral aspect of the distal femoral condyle. So we do expose that, and we do split the IT band to get access for placing the button. So it is open to incision there. We pass the subtle suture there. You can just see on the top of the arthroscopic pictures there's that Ethibond shuttle suture. Then we use an ACL guide to drill a guide pin in the ACL insertion. Over drill that. I use a 4mm drill over the pin, and then pass a shuttle suture, which is docked out of an accessory portal as well. So next, we use 2 number 2 vicryls that are passed through the ACL stump using your preferred suture passer. And to be part of this study, we need to make certain that each limb is passed 3 times through the ACL stump itself. So that's an inclusion criteria. So the ACL stump suture is then shuttled out of the medial portal and shuttled through the femoral button. And next, the femoral button is shuttled into the knee through the medial portal, up through the femoral tunnel, and engaged on the distal femur, therefore securing the ethibond sutures, which would be used for the scaffold. We do keep the ACL sutures lax. We put an Alice around there, but we do tension the ethibond scaffold sutures. So at this point, we create an arthrotomy. We make sure that there's no soft tissue bridges. I make sure that you can get a digit within the incision, and you can view that arthroscopically. Then we go and retrieve the tibial shuttle suture through the medial portal, which was extended. We change our gloves, but prior to this, we infuse the knee with Ancef or the appropriate antibiotics, which is a deviation from our typical practice, or my typical practice, but we did use an antibiotic flush during this procedure. Then we changed gloves for anyone who would be holding the collagen scaffold. So next we take those ethibond sutures that are docked on the distal femur, and we pass them through four passes through the bovine collagen scaffold, and then shuttle the ethibond sutures through that medial portal out through the tibia. Then we infuse the BEAR scaffold with whole blood. I asked the CRNA to get at least 20 cc's of whole blood, and we infuse that into the scaffold, which makes the relatively rigid scaffold soft and malleable enough to be inserted through the arthrotomy. So while pushing the scaffolds into the arthrotomy, the knee is extended and tension is placed on the ethibond sutures that are passed through the tibia. So then next we gently put tension on the vicral sutures that are passed out of the incision on the distal femur. And we have to make certain that at all points at this time that the femoral button is deployed on the cortex and doesn't get shifted where it gets sucked back into the tunnel on the femur. So here you have to summon your inner general surgeon, because again, these are not high tensile strength sutures that we've become accustomed to with arthroscopic techniques. So these are number 2 ethibond sutures that are passed through the button. You can kind of just barely see the button on those sutures demonstrated by the yellow arrow. We toggle that button down and then gently tie the sutures over that button on the tibial cortex. That is tensioning the scaffold sutures, the number 2 ethibond scaffold sutures. And then again, very gently, we're using number 2 vicryl here. We are pulling the ACL itself into the scaffold and repairing the ACL into the scaffold itself with knot tying through that incision. Again, it's essential that that button is deployed on the femoral cortex. Here are the radiographs of the button position here in a BEAR patient. And we all use the standard physical therapy protocol. Intraoperatively, we do not do a Lockman or pivot shift because this is not a structural construct. So, which was a little bit non-intuitive the first time doing a BEAR, of not doing a Lockman or a pivot shift to test our construct. So we keep the knee straight immediately post-operatively for at least 24 hours. We do use partial weight bearing up to 50% with crutches for 4 weeks. After 4 weeks, they can wean from crutches as appropriate. We did use a long leg drop lock brace for the first 6 weeks with gradual increasing range of motion over that period of time. And then we transitioned to a more functional ACL brace at 7 weeks. All patients underwent the standardized formal physical therapy program with home exercises. Physical therapy ranged from at least 6 to 9 months, with the earliest return to pivoting in competitive sports at 9 months, but determined functionally and individually by the individual surgeon and their physical therapy team. On the left side, we have the control uninjured ACL, two images that show the origin to the insertion. And we can see here an intact bear at 9 months, where at 9 months, the cross-sectional area of the bear is typically wider than the native ACL. But as you saw from one of the previous slides that Dr. Strickland showed, at 2 years, that's morphology of the bear ACL becomes more like the uninjured ACL as it determined as from a cross-sectional area standpoint compared to the uninjured knee. So BEAR 3 included 151 patients, almost exactly 50% male and female. The mean age was 27 years with a range of the youngest at 14 and the oldest at 62. A reasonable distribution among the four age quartiles that we see there. Was a relatively high level of activity of average patient with a mean Marks activity score of approximately 13. 82% were complete tears as determined by arthroscopic assessment by the surgeon. And the mean time from injury to surgery, again, was 37 days. Again, part of the inclusion criteria was that the time from injury to surgery had to be 50 days or less. Preoperative physical examination. The majority of patients had a mild to moderate effusion. 96% of patients had a soft endpoint. There was about a subset of patients that did have a KT1000 preoperatively, and intuitively, the injured knee had greater translation than the uninjured knee. Pivot shift tests was grade 1 and grade 2, the vast majority of patients on preoperative physical examination. And our mean Baton score is 1.7, but intuitively, the median was 0. Preoperative MRI findings, again, 95% had an effusion, 92% had the typical bone bruise pattern from an ACL pivot shift injury. Approximately 10% had a concomitant MCL injury. Roughly 1% had an LCL injury. Both the MCL and LCL injuries were treated non-operatively in this cohort. And the majority of patients from their preoperative MRI were determined to have either a type 2 or a type 3 ACL tear classification. So this is the intraoperative physical examination with the patient under anesthesia. The vast majority of patients had a pretty obvious Lockman from 6 millimeters and greater. Pivot shift test was worse on the intraoperative examination compared to the preoperative examination, which is intuitive, because the patient wasn't guarding or having pain while this test was performed, and the majority had either grade 1 or grade 2 pivot shift test. ACL tear type as identified by the operative surgeon, the majority of patients had a mid-substance tear, with about 1/3 of patients having a femoral avulsion. I believe there was 2 patients with a tibial avulsion. The surgeon was tasked to determine how much of the ACL stump was present at the beginning of surgery, where less than 50% was in 22%, 50 to 74% in 40% of patients, and 75 to 100% in a little bit over 1/3 of patients. And the mean amount of blood added to the implant was 13 milliliters. So intraoperative findings, interestingly, 50% of patients had a meniscus tear. 1/5 of these were medially, and the majority of these were repaired, where 39% were lateral, and only 28% of those were repaired. And so here's the 1-year outcomes. So for subsequent surgeries, 14% of patients had a additional surgery within the 1 year after the BEAR procedure. About 8% had a recurrent ACL rupture, but only 3.3% of these patients had a concomitant meniscal tear along with that ACL rupture. 1 patient had an isolated meniscus tear undergoing surgery. 6 patients had a surgery for arthrofibrosis. 1 patient had intra-articular suture removal from just having knee pain. And one of the patients had the femoral cortex button that dislodged into the femoral tunnel and underwent a revision repair shortly after the primary procedure. So for subsequent surgery, intuitively, younger age was a risk factor for recurrent ACL tears, with 16% of patients under 18 having a recurrent ACL tear, with only 3% of those over 18. So for patient-reported outcome measures for the IKDC was statistically greater than baseline for each time point at 6 months, 9 months, and 12 months. And for the KOOS, for all subscales of the KOOS at all time points, patients were statistically improved compared to the preoperative status. And again, this is intuitive and matches previous studies. The MARC score was statistically inferior for the two early time points, 9 months and 12 months compared to baseline. Again, age did have an effect on patient-reported outcomes. All postoperative IKD scores were statistically superior in patients younger than 18 compared to those that were older than 18. This was a similar finding for all subscores of the KOOS at all time points except for one. If you look at the third graph on the top, age effect on KOOS quality of life, the 12-month point was the only one that did not show a difference between ages. So again, age had an effect on the MARCS activity score, where younger patients had higher levels of activity. However, there were no differences between change from baseline to the postoperative time points at 9 months or 12 months. And lastly, we look at instability measures, and we start with the Lachman there. 92% of patients had a firm endpoint in the bare knee compared to 100% in the uninjured knee, and that was statistically relevant. The Lachman grades were, according to the IKD scores, were also inferior in the bare knee to the uninjured knee, as we can see in this graph to the left. So when looking at 1 year, comparing patients, 71% of patients had no difference in their IKDC Lachman compared to their uninjured knee, where roughly 1/4 of patients were 1 stage worse. 3 patients were 2 stages worse, and interestingly, 2 patients were 1 stage better in the bare knee compared to the uninjured knee. For pivot shift testing, with an 83% follow-up specifically for the pivot shift test, the pivot shift test IKDC grades were inferior in the bare knee compared to the uninjured knee. And for the subset of patients that did have a KT1000 preoperatively and postoperatively, the KT1000 values were inferior in the bare compared to the uninjured knee, with 3.3 millimeters in the bare knee and 1.8 millimeters in the uninjured knee.
Thank you. I'm Jackie Brady, and along with Dr. Strickland, we're the co-PIs for the Bridge Registry, and Dr. Wittstein is our lead writer and the true scientist among us. So she'll get into the weeds a little bit on the data, but I'll give you a little bit of an intro. While I'm getting started with that, I wanted to plug the Q&A section of this webinar. Please feel free to throw questions in as they occur to you. And if it's relevant, we'll sort of interrupt ourselves and address them. But there will be some time for discussion at the end as well. So let's talk about the Bridge Registry. Like we said, this is the multi-center study that's allowing surgeons to be unencumbered by the original technique, and also not necessarily directed in terms of timing. And so we get a little more variety here. So the projected end date is 2027 to get our 750 patients enrolled. So far, we have 224. You can see the sites listed here. We completed our 1-year analysis in September, and so that's what we're going to focus on here. The goal here is a post-market clinical study that will be continuing to collect data on patients treated with the BEAR implant in a commercial setting. So unrestricted inclusion, exclusion criteria, you saw the age range of 7 to 70, I believe, before. So very wide range that we can include here. So current enrollment 224, we have 9 sites. We have 152 patients that have reached 1 year at this point. We have 76 that have reached 2 years. And then we'll see the interim analysis here with this first 100. So this is the first 100 subjects at 1 year. Of those, 29 are at 2 years. So a little bit of a range. 4 of the subjects exited early, 1 at 3 months, 2 at 6 months, and 1 at 9 months. Of the 100 subjects, 94 of them were retrospective. And so we caught them at their first post-op visit after the study was begun. And then 6 are prospective. And you can see the enrollment distribution here for those first 100. And then here are the demographics. So the age is pretty well distributed. More female than male, and mostly proximal tears, but a good number of mid-substance and 1% distal. And then I'll turn it over to Dr. Wittstein here.
Thanks. And then Jackie, can you go back to that last slide just for one moment? The other kind of aspect to zone in on there is that the mean time from injury to surgery is also, like the age, much broader. So, you know, we've got a minimum of 8 days, but a top number of 154. So, you know, with surgeons judging intraoperatively, you know, looking at the ACL stump at the time of repair, kind of determining that this is still appropriate based on the quality of the tissue, but still a much broader range. So, okay, next slide. All right, so we mentioned the tear types, similar to other studies, you know, these tend to be utilized on more proximal mid-substance injuries. Looking at our surgical techniques, we had one associated with an LET. And one of the things that really sets this study group apart is that there are a lot of modifications in the technique used. So 50 of these subjects in this group of the first 100 had the classic, you know, Martha Murray technique that Keith so nicely described. But 50 had modifications. And when we say modifications, what we're talking about is any modification from that standard technique. So it could be luggage tag sutures were used instead of Bonnell's. The ACL suture instead of Vicryl might have been a suture tape or some other, you know, higher strength suture. An anchor could have been used on the lateral wall of the notch versus a button, or a tibial anchor instead of a button for the fixation on the proximal tibia. And then alternate bracing sutures. So that suture that you pass through the BEAR implant using tape or something other than Ethibond. Next slide. Our overall reoperation rate at 1 year was 8.4%. When we look at this whole cohort, including, you know, in this first 100, including those that were at 2 years, there's a 2% re-tear rate. Both of those re-tears occurred between 1 and 2 years, one in a 17-year-old with a non-contact pivot injury while playing basketball at about 14 months, and then another in a 15-year-old while playing hockey at 23 months. So right near the end of that range that we were catching data out to 2 years. There was a single contralateral injury that occurred, and then 4% of this group sustained meniscus injuries. Other surgeries that were performed were manipulations under anesthesia, and then removal of the Ethibond suture from the notch in 4 of these cases. Next slide. Our PROs are a little different than those that Keith so nicely presented in the BEAR 3 series, partly because in this first 100, so many of them were enrolled after the initial surgery, so kind of catching them at that first post-operative visit. So we don't have that great pre-operative data in some of this group, but looking at our PROs at 1 year reported in 79 of this 100, you can see these patients have high IKD scores. The MARC scores with an average of 7.5 are certainly a lower activity level than they were at 1 year in the BEAR 3 group. RSI is about 67. The Q scores were all quite high, as you can see there. Looking at the physical examination, this is available in 75 of these 100 patients. The overwhelming majority of them had very little translation on Lachman, 0 to 2 millimeters and 80%, and then 3 to 5 millimeters of translation and 20%, with a firm endpoint noted on most of these patients. The pivot shift was performed in 73 of the 100 at 1 year. A lot of these patients are missing some of that physical exam data due to virtual visits at 1 year to confirm that they hadn't had any re-injuries. We'll see larger numbers of physical examination going forward with the registry with all in-person follow-ups, but in the pivot shift for this group, 90% of them were negative, 8.2% were grade 1, and a very small fraction, 1.4%, were grade 2. So looking at the technique modifications, the registry was not designed to compare modifications versus traditional techniques, but we are seeing in the course of the registry over time, increased utilization of technique modifications, especially with increasing use of the button on the femur, the anchor on the femur rather than the button. We didn't see any difference in safety outcomes when comparing the 50 that had the procedure by the classic technique and those that had a modification of some sort. The most common modifications we're seeing again, or use, at least in this first 100, then also going forward, is use of the anchor on the lateral wall. In this first 100, only 17 had the anchor rather than the button, but you'll see going forward there are more people doing that. Using a tibial button versus anchor was another common variation. In this group, the anchor was used in 43 out of 100. And then again, using alternative ACL stump suture, you can see here what the distribution there was. So in this group, 84 had the vicryl on the ACL stump, but other sutures were used in 16 of these cases. Luggage tags were used in 13 of the cases as opposed to Benel. And then using an alternative suture to go through the BEAR implant, we see that 39 out of the 100 used an alternative suture other than Ethibond. A lot of these were suture tape. Next slide. Looking, when we say inclusive of all subjects, we mean the whole group that's been enrolled in this BEAR registry, not including, beyond the first 100. So now you can see there's an even greater shift towards use of modifications. If you look at femoral fixation, looking at these 224 patients, there's a little bit higher use of the anchor. Now we see 30% with the anchor. The tibial fixation, I would say, is pretty similar. We're seeing 55% use of the anchor. Alternate stump suture, still seeing majority being done with vicryl, but you can see like some gradual increased utilization of other types of suture. And then the suture that's passed through the BEAR implant, definitely seeing a greater shift towards suture tape and things other than Ethibond. Next slide. So just so people have an image, we wanted to show you a couple of examples. So this would be an example of using the BEAR implant with luggage tags and a femoral anchor. Just a little notchplasty there. And then these are luggage tags instead of the Benel suturing, and then those are taken to an anchor on the lateral wall. Next slide. And then here's the passage through the tibial footprint and then placement of the dunking suture. And then you can see that there are those sutures that are exiting from the anchor on the femoral wall, which will be used to pass through the BEAR implant. Next slide. Another technique is the BEAR implant with Benel stitch and a femoral anchor. So the Benel stitch is, of course, the classic technique, but the anchor is the variation. So here's Benel suturing, and then this is placement of an interference type anchor on the femoral wall to secure it. So that's different than attaching it to a button, clearly. Next slide. And then the third variation we just wanted to highlight is use of the BEAR implant with a ring type suspensory device. So this would be passing. Here we're just showing the prep here. Next slide. This is kind of drilling, from the outside in. And then these are rings that you can pass a tensionable suture loop through. Next slide. And then the tensionable suture loop is pulled in just like you would pull in the button on a traditional technique. Next slide. And at this point, you can partially tension the tensionable suture loop. And you have 4 tails of suture that were also passed through that button that can be used to go into the BEAR implant and then completed. And you can subsequently tension the implant, the tensionable suture loop more if you want after you've inserted the BEAR implant. So, next slide. In rare cases where second look arthroscopies have been done, this was a case or two, I think, with arthrofibrosis. There was a limited number of those, but you can see here there is quite a lot of collagen here, and that looks like an ACL that you might see in the setting of a little arthrofibrosis that we don't want to get too close to, but there's definitely a very recognizable structure within the notch there. So next slide. I'm gonna let Jackie wrap up with the last slide here.
Right. So yeah, we're hoping to continue our projects here. We've got abstracts submitted to ANA and AOSSM for the safety data. and the physical exam and outcomes of these first 100 patients. We're hoping to create a publication of all the various technique modifications that have been used for the public to be able to reference as they take on the BEAR procedure. And then because some of these outcomes seem to differ, we're hoping to compare our cohort to the BEAR 3 group. And we're working out how to do that in the most valid way, because we can talk about modified technique, but that really includes a lot of variations. And so we want to make sure that we're pure with our data there. Awesome, which I think brings us to the Q&A. I don't see any yet in the Q&A section.
So I would say while we're seeing if any of the attendees have any questions, we could maybe go down amongst ourselves and just talk about how we're doing it now. I think maybe let's start with Keith, because you've probably been doing this longer than us.
Yeah, so all my first patients were obviously the Dr. Martha Meany Murray technique. And once the study we were finished recruiting, I was able to branch out. And one of the things I always thought, well, we're staring at the IT band. Why not do an IT band tenodesis if we have an open incision through there? So right afterwards, I did a concomitant IT band tenodesis. And then I've transitioned to doing an all inside using suture tapes, not having to make that incision. So unless a patient's not ligamentously laxed, if they don't have hyperextension of their opposite knee on clinical examination, I won't do the IT band tenodesis, and I'll do an all inside with a internal bracing type buttress there. And I do now do a Lockman and a pivot shift test, and it feels so good to be able to do that again.
We have a couple of questions, but why don't we just, and what about you, Jackie?
I had been doing a button with a braided tape type suture as the bracing suture and a Vicryl pretty religiously. And recently with the IV fluid shortage, in order to expedite, I did an anchor as my fixation and did a sort of luggage tag link type suture. And I loved the ability to see the repair come together, because if you do the tying over button, you don't get to visualize the reduction of the thing. You can sort of simulate it if you put a tool in there, but I really found that to be very rewarding. So I think I might actually stick with the anchor in the wall.
Jocelyn?
Yeah, the first couple I did in the classic technique, and then I transitioned to the anchor in the wall with a tape type suture and an internal brace. But I kind of have now sometimes, depending on how mobile the stump is, I will sometimes use the rings and the tensionable suture loop. I think one nice thing about that technique is you can kind of like pull the stump out of the way, advance the BEAR implant in, and then tension it. But there are a lot of these stumps that are kind of high grade partial, where there is some of that adherence somewhat to the PCL, where I think it's a little beneficial to just kind of have some stability to the stump as well. And I don't want to disrupt all of that. So in those cases, I like using the anchor because it's kind of already kind of sitting where it's supposed to sit. And then I don't want to disrupt all of that. So I kind of oscillate now between the tensionable loop with the rings and the anchor on the femoral wall.
Great. And now we have some questions. I mean, I switched pretty quickly from Ethibond to a higher strength suture, and I use sort of the standard all inside that I use for any other ACL reconstruction. So flip the button, tie, I still use Vicryl suture, but tie those Vicryls around the adjustable loop. So I do watch the stump go up to the wall before I put my BEAR implant in. As far as these questions, any difference in outcome, physical exam, PRO, re-rupture based on femoral avulsion versus mid-substance? Keith, did you see that?
We don't have at this point data to answer that question from a statistical standpoint, but no, we don't have that an answer to that.
And Jocelyn, as far as I know, we don't either.
I think to be determined with more enrollment.
Yeah.
And BEAR, is anyone comparing BEAR with LET versus BEAR alone? We have so few numbers, but there definitely are a few of us. I'm certainly, if I'm doing a BEAR and a younger cutting athlete, if it's anybody I would consider an LET in with a ACL reconstruction, then I'm considering it with a BEAR. And I know Sean Keys, who's a pediatric sports in Florida, he said he's essentially adding LET to a high number of his patients. So we will be looking at that. We just don't have anywhere near enough numbers yet.
Or that are at least a year out. Yeah, yeah.
What are physical exam milestones post-BEAR? How long before a gentle Lockman? Our study design for the registry prohibits Lockman before a 3-month visit, and I think a pivot shift before a 6-month visit, which is very, it's much the antithesis of my usual flow. But we don't want to disrupt that healing ligament, and so that's the earliest that I test a Lockman and a pivot shift. How about you guys?
I mean, I typically check Lockman at my 6-week post-op. I just can't, I don't pivot them, but I check Lockman and I don't worry about it.
Yeah, I don't do a Lockman until 3 months, but that's also what I've always done for a standard ACL reconstruction.
Oh, really?
Well, I mean, I check it in the OR with a standard ACL reconstruction and not with the BEAR, but I don't do a Lockman with someone until 3 months post-op from a regular ACL.
Yeah, with the BEAR 3, no Lockman for 3 months, no pivot shift tests for 6 months. Like I said, intraoperatively, if I'm putting tapes across there, I'm really testing the tapes itself. I'm not really testing the ligament repair itself. But I have no concerns of doing, for an ACL reconstruction, I'll test their Lockman at 2 weeks. So I differ from Dr. Wittstein there for a reconstruction.
Yeah, I don't think I have a concern about it. I just don't do it for 3 months because they're not doing anything to risk injury in general before that. But
that's fair. I think given that we're pouncing on these, well, I think based on the 50-day FDA approval, I realize our date from injury to surgery does vary a little bit. I'm most focused on range of motion in the early post-op exam. And so I think making sure that they get full extension back, making sure that their flexion is progressing well, that's the focus of that 2 and 6 week appointment.
The next question is, I've done 10 now and all but one that have hit 9 to 10 months. Post-op still seem to have laxity with Lockman and pivot shift. Admittedly, I've done patients 12 to 17 years old as I'm peds. What would your next steps be and would you be concerned? Anybody want to take this?
Yeah, it's not reassuring if your initial ones are showing objective differences or subjective differences to the stability there. The true test is the return to sport, and if they actually fail, if you do a hamstring, a lot of the hamstrings will have a lot more play than your typical BTB. So I'm sure that doesn't make you feel great, but I'm not certain that it means definitively that these patients are going to fail.
Or it may be helpful if you have access to it to get a KT or, see what the difference is, something like that. I know KTs are disappearing and I think no longer produced, so that's a challenge, but.
Yeah, and I think that's definitely a patient population that we think of for LET. And so perhaps, especially if the pivot shift is catching your eye, that might be a consideration to add that for future bears.
Yeah. I had one patient.
Will that person respond if it was a classic or modified technique it was probably classic.
Good question.
It would be great if you've been doing the classic technique, because I would say that since we've been using higher strength suture, we have found that at least the 80 or so that we've done at HSS, that they've been remarkably stable. Although I have had a couple that were definitely more lax than I would like, but overall I found them to be quite stable. The next question was, will you be comparing re-rupture rates for the different modern or classic techniques? used for BEAR once the registry is completed. I mean, I think that will be an important thing that we'll look at as the numbers are going up and for the different techniques. Do you have thoughts on that, Jocelyn?
Yeah, definitely. I think the issue right now is as people started modifying techniques, there was just a lot of variability in the way people were modifying. And I think we'll need larger numbers to kind of, I would say, like kind of lump certain modifications together. You know, like I imagine this will be easier to do with larger numbers, but you know, anchor fixation versus button and kind of lumping different types of suture material and things like that. But right now, we wanted to kind of initially just describe that we did have at least half of that group being modified, but it's kind of a mixed bag. So we don't want to draw conclusions too early, but it definitely has piqued our interest in this topic. And now we're kind of collecting more detailed information on the modifications so that we can do that analysis more carefully in the future.
And then maybe you can answer this, Jackie. For the majority of your cases, are you going in planning a BEAR, or are you telling them that it's going to be a game time decision?
I always know if I have a BEAR on the table, no pun intended. If we're thinking about BEAR, we sort of plan for BEAR as the first choice, and the discussion preoperatively generally involves, well, if it does not hold suture well, what's the backup plan? And sometimes the backup plan is stop, and we don't want to do any kind of graft harvest. We don't want to do anything BEAR or bust. We're going to stop. But generally speaking, it's an autograft of some sort. I have a generally pretty young patient population. And I think this really speaks to the MRI as a predictor of the quality of the remnant. There's a study out there that the MRI, or maybe it was just an abstract that I reviewed, that the MRI does not predict the quality of the ACL remnant very well. And I just experienced that today, where there was just a lot of edema in that ACL, but I thought I could see fibers, and it did indeed hold suture really well and reduce very nicely. So I think it's prudent to have a backup plan. But it's been very reassuring that it's been successful in the vast majority of cases that I've encountered.
Yeah, I think we all have the case where you're like, this is going to be a BEAR, and then it's not, or where you're like,
Right.
oh, not likely, but if you want it, I'll take a look, and then it surprises you and it looks better. I think the edema really can fool you, especially if the MRI is done pretty quickly after an injury.
Right.
I had a couple times where I got in there and I thought from the MRI it was a mid-substance, nothing left, and I was surprised to see how much of a stump was left that it could have been repaired, and I kicked myself for not consenting a patient for BEAR. So I found it's the opposite way. I find that I probably are too conservative, where I should consent more, because I think sometimes you can fix them when you don't think you can from the MRI interpretation.
Mm-hmm.
Does anybody have any thoughts about meniscal repairs, as far as, I assume the question was, are you more confident in concomitant meniscal repairs healing when utilizing BEAR in conjunction with an ACL repair? I mean, the question is, do we think BEAR is helping meniscal tears heal?
It's a great question that's unanswered at this point, but if you're putting a scaffold in there that kind of dissolves within the knee, can that assist in healing another area? We're intrigued by that, but we can't answer that at this point.
Mm-hmm. And we are drilling the notch. I think some people drill the notch in an ACL intact case just to try to enhance their meniscus healing. So hopefully that's giving us some boost as well.
And for those of you using a luggage tag on the stump, are you always using 3 luggage tags, or is there?
I would usually do 3.
I've done 2, I've done 3. I did one today where it seemed to have 2 bundles. There was one in each bundle and then one connecting the 2, and that seemed to reduce it nicely.
I do think I'm really grateful to have this option is, there's, before BEAR was an option, there were times you would do an ACL reconstruction and you would go in there and be like, gosh, that ACL looks really good. I feel terrible. I'm going to take this out. There's so much really good ACL there.
Yeah.
The ones that surprise you, like how good they look. And Yeah, so it's, I'm just kind of going back to that question about meniscus tears. I don't think, I still think it's debatable whether or not blood in the joint is good for meniscal healing. But I think the thing that really appeals to me with the BEAR implant is that, the animal data, of course, showed that there was lesser risk of progression to arthritis. And I really think that probably has something to do with that, with the implant being a material that is kind of absorbing and holding that blood and the fibrin clot, and perhaps having, less sort of diffuse hemarthrosis throughout the knee, like chronically after the reconstruction. So I think, we haven't really, even with the follow-up, scratched the surface of that potential benefit in humans, but I think those are things to come in the future with these follow-up studies.
And the ped sports person got back that she did use a modified technique with suture tape and femoral and tibial buttons using fiber wire, but recently has switched to an anchor in the femur. But all of those patients passed return to sport PT evals, and none expressed any instability with activity. And, I think, Keith, that was like an interesting point of, or data point on your study, that there was a statistical difference, but I think we have a lot of data in prior ACL studies suggesting that if you're a millimeter or two more lax, that doesn't functionally matter. So it might, it'd be great, Kristen, if you had a KT and had a number. I mean, we don't do KT on the vast majority of our patients. So, it'd be nice if you knew you were only feeling that extra millimeter or two, because it probably doesn't matter, but I don't think we know yet. I don't know if any of you have a comment.
Yeah, I think I've had some that feel like the sort of standard post reconstruction asymmetry that I've found, especially with soft tissue grafts. And so I suspect that this might be the same kind of scenario where they're clinically stable, but it's an asymmetrical exam. Yeah, I don't think anything else to add.
I have a couple patients where their bare side feels tighter. Like some people that have there are people that have intact ACLs that have quite a lot of anterior translation. So I do think there's like variation in that, but yeah, certainly just like with any ACL reconstruction, there is some asymmetry, I think.
And what are people using for retractors when pushing in the BEAR, like Army Navy, speculum, right angle retractors?
I usually use those Doane Z retractors, or maybe one on one side and an Army Navy on the other. That usually lets my sort of thumb get in.
I don't use a retractor. I just push it in through the arthrotomy.
Yeah, I think a mixture of Z and Army Navy. I do find if I don't have any retractor in there, there's some of the BEAR, like I call it like lost on entry, like kind of like a rocket ship. But I think that it's kind of probably purposely designed in that way to like maybe lose a little material on the way in. But I've try to use some low profile retractors and also push it in before it's completely squishy, like because it is gonna get smaller. Like you want it to be a little firm when you push it in, not too soft, because then it does break down too much.
Yeah, I tend to use Army Navies, but there are some patients who are just have a very, I don't know if they have a large patella or a very stiff patellar tendon where it's you lose more because you have less access and you're not going to make a large arthrotomy. So and there are some surgeons who are just putting it in through a syringe or using another product to essentially deliver the BEAR.
I had the opportunity to go down to Stanford as Dr. Sherman was starting to take up this technique. He's one of our sites for the Bridge Registry, and we dissected the specimen after practicing the procedure. And I found that really informative because it truly just forms a hydrogel over the top of your repaired ACL. And I guess previous to that, I had thought of it as some structural thing that I just couldn't lose any. And it was really reassuring to see it just be a hydrogel. And so if you lose a little on the sides on the way in, I think that's sort of minimal harm. I do try to scoop it up and kind of stick it back in, but I think you're right. Someone's lost that entry. And I think that truly is okay. It's designed to be okay.
You guys use antibiotics, insufflate with antibiotics at all during the case?
I do right before I put the implant in.
I've not been doing that. I think
There,
Jocelyn, just irrigate and dry.
Yeah, I just irrigate with antibiotics. I mean, just
Yeah.
like we were, we soak every graft in vancomycin. I just irrigate with the same.
Hmm.
How many football players in the study and return to sport data? So we really don't have a return to sport data yet on the Bridge Registry. We do have it. You do have it for BEAR 3.
Yeah, we haven't broken it down by sport yet because it's really only 1 year. We haven't critically analyzed the return to sport data yet. I would say that half of my patients were high school football players.
That's great. Yeah, I'm looking forward to that breakdown by sport as well. And there's so we were asked to sort of go over the current BEAR related studies. You guys heard mostly about BEAR 3 and the registry today, but there's also the BEAR Moon, which is comparing the BEAR in randomized controlled fashion to patellar tendon autograft, which I think will be very revealing in very high risk sporting athletes. I guess if you guys have any other questions about the specific studies, please chime in. Descriptions.
And I'm sure as the study evolves and more people utilize BEAR, I think most of us started with our sort of lower risk, lower demand, at least in New York, I started with skiers or a true weekend warrior who really wasn't playing a lot of cutting sports. But I think the more I've done, I've been impressed with my results. So it expanded my indications.
Are you guys playing around with the timing much, or I don't have a good concept of whether my colleagues here have a lot of variability in their timing. Do you adhere to the, I guess, Keith, you probably would adhere to the 50-day cutoff because of the indications on the FDA approval?
I've expanded a little bit. I actually, Dr. McMillan, who's both part of BEAR 3 and part of the registry, I picked his brain on a patient that was further out, and so I'm a little bit more liberal now with not holding them straight to 50 days there.
Good to know.
But I think your point earlier, or maybe it was Jackie's point, and actually it could have been Jocelyn's, but the point is like, sometimes you get in there and you wish you'd consent. I think it was Keith's point, wished you'd consented them. And I think, it's a little bit much in clinic to talk about every possible option with every single patient. But I think having as an option that if you get in there and there's really good quality tissue that you can pivot, I think that's a really nice option. Because I agree, it's in some of these cases when you're basically taking down the entire ACL that's scarred to the PCL, it's really nice when you don't have to do that. So I think we're a minute over time. I think this was great. I really appreciate everybody with all of their questions. And if you have further questions, you can certainly reach out to your Miach rep, and they can put you in touch with one of us, and we can try our best to answer any questions. But I hope everybody has a great night, and thank you so much.
Thank you.
Thanks.